Professor Buchholz, who founded the endoclinic, was the first one who did a total hip replacement in 1963 in Germany, and he developed the concept. Here you see the X-ray. This was the first total joint double hip replacement in Germany in 1963. And he was very interested in the topic. He got more and more specialized in the 60s. And because of the fact that his infection rate was about 8–9% during this time, in the middle of the 60s, he came to the idea, and he's mentioning it in this letter, to add antibiotics to the bone cement. This letter is 50 years old. And that was the beginning of the admixture of antibiotics to the bone cement. The goal was to react on remaining bacteria and function as a barrier against recolonization. He published it in his first results, especially by usage of antibiotic-loaded bone cement in periprosthetic joint infection. He published his first results in 1972 about it, and he did it during this time in a one-stage procedure. So, but we all know that still the gold standard worldwide, and here also in Ecuador, is of course the two-stage exchange. But there I will put a big question mark behind it. We have pros and cons regarding two-stage and one-stage, and in my opinion there are more pros than cons for the one-stage. Our therapy algorithm in the endoclinic is, if we have a major biofilm, we have chronic infection, and the questions are, do we know the pathogen? Do we know the susceptibility? Are there any local antibiotic therapy possible? And is a radical debridement possible? And if we answer all these questions with yes, we go for a one-stage exchange. If otherwise, we do the two-stage exchange. So that means the majority of our cases is done by the one-stage exchange, 90%, and only 10% in the two-stage exchange. There we do still, but only in the very, very early postoperative period, only within the first 2 to 3 weeks. The key of the success in one stage is the knowledge of the germ, of the bacteria. We have to know which germs are responsible for the PGI and something about the susceptibility. So to make it even easier, if we know the germ and the susceptibility, we do the one-stage exchange. If not, we go for the two-stage. The principles and techniques of septic exchange, independently if it is a one-stage or a two-stage, you can see here. Well, the main principle is removal of all foreign bodies. And we have problems by doing this. Of course, removal of fully integrated components, we have heard it yesterday, removal of the complete cement mantle. There are some approaches possible, endofemoral, transfemoral, ETO, or fenestration. We, in the endoclinic at least, we do not like the ETO so much. ETO, of course, is quick, is very suitable for less experienced surgeons, and it is easier to remove the implant and the cement. But ETO, especially in infections, have a high rate of non-union, possible contamination of non-infected soft tissue outside the infected femoral canal, and radical debridement after failure is much more challenging. So that's why we try to avoid ETO in all our cases. We never do an ETO, believe it or not. We do a fenestration or nothing else. And I was sitting together with Ray Paprosky and David Levine last weekend, and Ray mentioned, it was interesting, he mentioned, in his opinion, as more experienced you are, as less ETOs you are doing. And this is exactly my opinion. So we try to avoid an ETO. Second, again, we have to remove everything, and the second basic is the radical debridement. But what means radical debridement? That means removal of all kinds of infected tissue and bone. And the challenge is always to find the interface, like a tumor surgeon, to the healthy tissue. And this is the most challenging part of the surgery, and this differentiates an experienced from an unexperienced surgeon. It is a very, very slow learning curve. In our hospital, the surgeons who are doing this kind of surgery are all very experienced surgeons, and they have a training of at least 2 years to do this before I allow them to do a septic revision. For 2 years in every surgery there has to be an experienced septic surgeon on the side. 2 years. Radical debridement includes the capsule, the bone and the soft tissue again, and sometimes if the bone is really infected, you have to go, or you have to remove the bone. And you have to be very strict and consequent. Radical debridement, this was a typical case. I opened it and I saw that the whole proximal part of the femur was infected, and there's no doubt. Then I cut the femur and remove it. And this is radical debridement. Another basic principle of the one stage is the preparation of the bone cement with antibiotics. So this is another challenge. You need a very experienced microbiologist who recommends you, depending on the susceptibility of the germ, which antibiotics you have to use in your bone cement and which kind of antibiotics you have to give after the surgery. The principles here, this is an infected case. The principles are simple. Removal of all foreign bodies, curettage of the femoral canal, usage of pulsatile bedjet lavage, remove all the very good integrated components, start with systemic antibiotic therapy after getting the last sample, change any contaminated material, and then re-cement the prosthesis with antibiotic-loaded bone cement. Here we use vancomycin and gentamicin cement. And then you just re-cement the prosthesis. You can say this is a disadvantage, especially in the femur, that is, of course, because you are re-cement in a poor bone bed, where sometimes an uncemented revision stem would be much better. Our typical clinical pathway is the patient comes to the hospital for admission. We prepare every patient for 1 day because many of them have all kinds of comorbidities. We operate them 12 days, just 12 days antibiotics, IV, stop antibiotics, and the patient is gone. What's about our results? That was only the publication of this year's. We did a comparative study, which is in press at the moment, of our one-stage and two-stage complications, and that was so we looked after almost 400 one-stages and 44 two-stages because we don't do so many two-stages. Regarding the surgical complication, it was similar, one-stage and two-stage. But the medical complications of the patients were much higher regarding morbidity of the patients in the two-stage, and the mortality rate was almost 5 times higher when we did the two-stage. But to be honest, there is a big bias in the study because we do only the two-stage of difficult cases, the very difficult cases. Then we ask, what are the factors associated with re-revision after one stage? And here you see what are the independent risk factors of failure for any reason. It was significantly prolonged wound drainage, very, very high risk. Previous septic revision also. And our indications for re-revisions, of course, number one is 44% dislocation. This is still in our hospital an unsolved issue. And then we published in JJBJS 2 or 3 months ago what risk factors for failure after one-stage exchange for the knee arthroplasty. And we looked after almost 700 one-stage exchanges in total knee arthroplasty. We looked for the patient-related and procedure-related risk factor for failures, and we compared more than 45 factors. So mean time to failure in our patient group, one stages, was almost 2 years. And then here are the top 3 causes for failure of one stage: recurrence of infection, aseptic loosening, and patellar problems in the knee. Here you see the risk factors. The odds ratio was, and this is very interesting, the highest risk is infection with enterococcus. If you have a patient with enterococci, you have a very high risk if you do one stage to get a new infection, reinfection. Prior one stage was a very high risk, persistent wound drainage, and so on. So this is our ranking, and additionally we saw streptococci are also on a high risk. 3 times higher risk to get a reinfection. That led to the fact that if we have an enterococci infection, we go probably in the future more for a 2-stage. Here are the independent risk factors regarding the regression model, history of 1-stage and 2-stage, isolation of streptococci and isolation of enterococcus, and last but not least, what are the long-term results? In our hips 1-stage exchange, we reported or published an infection-free survival after 10 years of 94%. Thank you very much.